Good morning, Doc. This is a Invisalign case you wanted some help with. As you identified, this is a Class 3 case. And let's walk through. I'm going to take off the attachments, the IPR, and so on and so forth. So we know when we look at the molars, we can gain a sense of the malocclusion through the relationship of the molars. This is an obvious Class 3 situation. Whenever I see a Class 3 situation, I always want to look at the canines and see if they're also in Class 3. If there's a discrepancy between those, it's often because there's teeth missing. And one would think that it's easy to find missing teeth. I think they're easy to overlook. So this is kind of it's an easy way for us to make sure that we're not missing any teeth, which can help us with the diagnosis. So Class 3 molar, Class 3 canine. Very Class 3 anterior relationship. Now the question is this dental Class 3 or skeletal Class 3? Simply looking from the side, I think we've got the answer here that they're skeletal Class 3, but this is let's just say we didn't have that information. If you come over, if you see this relationship here, there's no missing teeth, and then you come over to the Bolton analysis. If I click on this and it's under 1, but the patient presents with this severe Class 3, then the patient's skeletal Class 3, because the Bolton analysis measures tooth width discrepancies. So when we click on this here, we can see we're under 1, which is, I don't want to say normal, but it's definitely not severe. If this was a dental Class 1 situation, or sorry, dental Class 3 situation, we would see these numbers far north of 1. We have a Bolton analysis video where I go through the details on what this number means and how we use it clinically in diagnosis and treatment planning. But this patient's skeletally Class 3, as you identified. Upper spacing and lower crowding is typically when we see the Bolton analysis. Upper spacing, lower crowding with a Class 1 molar, Class 1 canine. It's typically the Bolton analysis presentation. Or, sorry, the Bolton presentation. The analysis is what tells us there's a discrepancy. I always like to look at the midlines. The midlines are relatively close, nothing to write home about. I also want to know is the left side and the right side, are the left sides and the right sides relatively equivalent in their discrepancy. You can see the canines are actually relatively closer to Class 1 than the right side. We see this gap here, which makes sense because we have this midline discrepancy. So these are just thoughts that I have when I'm first looking at the case. Before I start thinking about buttons and where the teeth are going to end up, it's really good in your mind's eye to have a good idea what the diagnosis is. I'll take this a step further and say this might be a case that really should require an analysis on the CAT scan or the Ceph. I think all orthodontic cases should have that kind of workup. In the world of clear aligner therapies, that's becoming less and less common as more and more general dentists are doing this kind of care. They don't have that technology. So if you have access to that, I would encourage you to do so. With that said, what is that going to tell you? It's going to tell you she's got a skeletal discrepancy. So how I would reason this is I would tell the patient, are you open to orthognathic surgery? If they were, then I would say, I'd like you to see the oral surgeon and or the orthodontist to get a Ceph to determine whether or not that is needed or not. If the patient says absolutely not, then I'm not necessarily sure that the information from the Ceph is going to be helpful in determining how we're going to solve this case. So I'll let you resolve that however you do. I'm going to move forward with the assumption that this patient doesn't want orthognathic surgery. Therefore, we do not have a Ceph or a CAT scan, and we're going to do our best with the information we have in front of us. Okay. So again, Class 3 situation, anterior upper spacing. The lower teeth are relatively straight. There's no crowding here, so it's really just a matter of picturing in our mind's eye how we want to solve this. All right. So there's a couple different ways to do it. The way that Invisalign is going to automatically solve this is add a lot of IPR to the lower, which I believe they had done. So we have 0.5 millimeters all the way across. And I'm going to take the upper out because the upper has spacing, so the spacing has nothing to do with IPR. And just looking at the lower arch, we have a relatively exaggerated curve of SPE. Do we need to level the curve of SPE? Well, it's not a deep bite case, so I don't necessarily think that's going to be a primary treatment objective, but I think it's something we should keep in the back of our mind as we put this case together. But when it comes to IPR, how much is too much? Well, Invisalign has an upper limit of 0.5 because somewhere in the literature there's something that says anything beyond that might put the teeth at risk for future decay. I think the literature is going to bore this question out more and more as time goes on, as more and more general dentists are starting to do IPR. But what I will say, I'm less likely to do IPR when the teeth are square, and I'm much more likely to do it when they're triangular. These teeth are on the square end. And what that means is when you do the IPR, you're more likely to reduce the thin enamel that's at the CEJ down here, maybe putting the patient at higher risk for decay down the road. I don't want to say that's going to be an absolute, but it's something to consider. So here I would say I'm willing to do some IPR. 0.5 I think is a lot. Now the reality is even 0.5 in all these teeth is not even going to come close to solving this sagittal discrepancy. So your question in the email was, is this too much? The answer is maybe, maybe not. But the real answer is it's probably not even enough. In other words, we're not going to get a sagittal correction of this malocclusion through lower IPR alone. So we have a couple options. One is we can increase the IPR of the posterior teeth. It's hard to do and hard to do well. If you do decide to do posterior IPR, I would recommend that during that appointment you take some bite wings to make sure that you've created nice reduction of two surfaces and not necessarily any ledging. It's easy to ledge. It's also easy to not realize you ledge until you're done ortho 3 years later and they have decay on the ledge that you created 3 years prior. So I don't love IPR here as a standalone treatment. This is a severe situation. If we wanted to gain a sense of how much discrepancy we have, we're a full cusp class 3, meaning this cusp tip should be here is actually, almost one full cusp distance away. So IPR alone, I don't love the idea, in great part because we're so severe class 3, but we also have spacing on the upper. So let's just say we're going to table the idea of IPR for now. Well, the other option when solving either a skeletal sagittal discrepancy or a Bolton discrepancy is to create spacing in one of the arches. And in this case here, we could create spacing. And as you said in the email, the primate space is something we can create. If that's a treatment goal, that is a way for us to solve this. I don't think this is an aesthetic outcome, but it's definitely a biomechanically favorable outcome. But I would probably try to get the canine into class 1, create the space behind the canine, and gain the advantage of true canine guidance, push the primate space posterior to the canine, same over here, and just leave everything in the posterior. As we know, moving posterior teeth is challenging, which is why Invisalign will almost automatically default to solving these problems with anterior solutions. In order to use posterior solutions, there's a whole host of issues or a whole host of methods that we can use, which I'm going to talk about in a second. So if the solution is going to be primate space, I would recommend we put it behind the canine. I would also have the patient sign a consent form that he or she understands what they're going to be receiving. And the way I would word it to the patient is, we're doing this because you have a skeletal discrepancy, because you don't want to do surgery. This is a necessary compromise. I don't want to say necessary. It is a compromise, and it is a solution. Here's what I would do. Again, the patient doesn't want to do orthognathic surgery here. I would use a Carriere appliance. So Carriere appliances are, let me just bring it up here. Carriere motion appliance. were developed by a French orthodontist to solve sagittal discrepancies. And for the most part, it's used in class 2 situations. In growing adolescents for class 2s, I've had massive success with this. It's just insane what happens. And the advantage here, I think of this as like poor man's orthognathic surgery. Because what you're doing is you're not actually retracting or advancing the maxilla or the teeth within the maxilla. You're actually creating a force that creates bone just mesial to the force, or just distal to the force in the case of a class 3 setup. So let's see if there's a class 3, right here. So this would be the class 3 setup, and there's several different ways of using this tool. This patient is not too dissimilar from the one that you presented with. You can see this is actually a 100% full cusp class 3 discrepancy. In the case of the class 3, the Carriere goes on the bottom. There's 2 elastics. Read the directions on how to use the elastics. It's relatively straightforward. But these are orthopedic elastics. These are not orthodontic elastics, even though we're using it for orthodontic purposes. The idea of an orthopedic elastic means the forces are far greater than orthodontic elastics. Orthodontic elastics are meant to move teeth. Orthopedic elastics are meant to move bone or create bone. So these forces are much greater. So you have to follow the recipe of elastics. There's what's called force 1 and then force 2. And those forces are rather significant to the point where they actually create additional bone through Wolff's law. Wolff's law being you apply force to bone, things will happen. So the lower Carriere goes on, you have to make a measurement, you put it from the canine to the first molar. There are different ways of using different length Carriere appliances, but more often than not, this is the setup. There's a hook here, and then you decide to put it on either a button or the Invisalign tray. Historically, classed sagittal discrepancies with Invisalign, the force was put on the tray, which had a vector of force in the direction of the elastic. The problem is there's also a vector of force that pulls the teeth down. So now, more often than not, we're actually putting, at least with the Carriere appliances, we're putting on the elastic onto a button on the tooth and a cutout on the tray. So this is what I would potentially do. I would loop in Dr. Fournier. He's somebody you and I have talked about. He's an orthodontist who has a lot of experience with Carrieres. I would loop him in with a setup if you decide to go down this road. I do not have any experience with class 3 setups with Carrieres, but I've had many successful cases with class 2s, especially in the growing adolescent. So anyways, that's the idea of a Carriere motion appliance. So that would be one way to solve this, and essentially what you'd be doing is you're actually moving the maxilla anteriorly and creating bone. That's a much more favorable situation. If you think about it, that's really the same thing that orthognathic surgery is doing. This is a lot less surgical. With that said, it takes time and compliance, bringing the elastics and patient buy-in. Another way of solving a sagittal discrepancy is a technique that's not used that much anymore, in great part because we have these more advanced techniques, such as the Carriere motion appliance, but it's called segmental distalization in class 2 situations. In this case, segmental mesialization. And what that would involve is actually moving one tooth at a time. You can imagine that if you asked Invisalign to close this space through mesialization of these 5 teeth, you're not going to get that. You're just not going to get tracking. After about 3 or 4 trays, you're going to start to see gaps underneath because the teeth aren't moving as well as intended. As a matter of fact, it's possible that Invisalign has algorithms in their AI that will just say that's not even possible. So the way to do it, although it takes a lot of time, is to move one tooth at a time, or sometimes even move one tooth at a time and create 0.5 millimeters of space, then move the next tooth, move 2 teeth at a time. So there's different ways of doing it. The point is you're moving one tooth at a time to fix the discrepancy. And I think that's an option here, but you're going to be looking at maybe 2 years, 2.5 years of treatment time because it's a slow process when you're moving one tooth at a time. That would also involve very significant patient compliance. That's a tough movement to do. patient is suspect at all that they're not going to be super compliant with their trays, that's not a movement you're going to want to do with clear aligners. So those are the options. My recommendation would be the Carriere. Again, reach out to Dr. Fournier and I can help you with that. Basically what would happen is you put the Carriere on the bottom, you close this space through the use of the Carriere appliance. The patient would have lower trays during that time period. I would probably say, I'm not sure if I would do IPR in the beginning. I might actually just try to do the sagittal discrepancy. With that said, these are severely tilted, and even with a very solid correction through the use of the Carriere, these are still going to be tilted. So maybe you do some IPR in the beginning. I would probably do 0.3 millimeters. It's just experience speaking. There's no science behind why I would do that. Alternatively, you can just wait until you see how much you're going to close with the Carriere appliance or with the segmental mesialization, and then you can determine how much you're going to have to, how much space you're going to have to create, or how much space you're going to have to leave through the use of a primate space. I would also talk to the patient about just how severely tilted these teeth are. I would highly recommend a night guard / retainer when we're done, which I'm sure you're going to plan, but I would build the value of the retainer in the eyes of the patient being multifold, meaning its retention and protection of biomechanical forces due to the severe, I'll say severe, the moderately severe angle of these teeth. The proper angle to these teeth is 135 degrees. It's called the interincisal angle of the anterior coupling. This is 180 degrees, meaning they're relatively parallel. Some might say 0 degrees, depending upon your point of reference. The point is, they're not normal. So that's pretty much it. You had talked about adding composite to the front. Absolutely. Do we do that first or after? Frankly, I don't think it matters. In general, I'd like to go after because if I'm going to do work, I'd rather do it when the teeth are done so I can make sure that everything's lined up well. If you do it at the beginning, you run the risk of having to do it again if the incisal edges aren't where they need to be based upon differences in tooth movement. So, pretty tough case. I think you get the idea about the orthognathic surgery. I think we've talked a lot about sagittal discrepancies and ways to approach them. If you decide to do segmental distalization, then you're going to want to have vertical attachments beveled to the distal so that the vector of force can be pushed anteriorly. And you'll also want to program in, I would say, 10 to 15 degrees of mesial root tip so that you don't get dumping as you mesialize these teeth. And what I mean by that is if you have a vertical attachment here and the tray is pushing, you're not going to get 100% translation mesially of the tooth from crown to root. You're going to get dumping to some degree. That's true in all orthodontics. So the way we set up cases is to account for the fact that the rotation of access and the moment of forces are likely to create situations where dumping occurs. You're going to want to build that into the equation. What I would do is a vertical 4 millimeter vertical horizontal attachment bevel to the distal, and then I would ask the technicians to program in 15 extra degrees of mesial root tip. And what that'll do is as you're segmentally distalizing these, you're more likely to get parallel movement or parallel translation of the entire tooth rather than tipping. If you have any questions about that, let me know. This is advanced stuff. With that said, it might be a good case to dabble with this. This is not a case I would get any black dots. If you get black dots, I would probably think about doing something different. Black dots, when you're talking about a case of this significance, is just not, it's not predictable. The blue dots even in that arena too. I think you and I have talked about if there's blue dots and black dots, you're more likely to do 10 days of tray wear versus 7. No science behind that yet, but I think experience would tell us that the harder the movement, the longer the patient should be in the tray. Alternatively, you can slow down the velocity of tooth movement too. So you can have Invisalign come up with the treatment and then say, please double the number of trays, and then have the patient change them every 5 days. That is a technique that I think is worth considering for tougher movements like this. If you need any help with that, I'd be happy to help. All right, good case. Keep me posted. Let me know how I can help, and definitely have the conversation about orthognathic surgery. If not, we have a couple different tools in the toolbox we can use to get this patient to a much better aesthetic and biomechanical situation. Have a good day.